So thank you very much for that very kind introduction. I've also been a fan of the TRI's mission and work for a long time now. So it's a pleasure to be able to participate in this lecture series. As mentioned, my name is Stephen Marcrum, and I've been involved in tinnitus treatment, primarily in the form of hearing aids and or cochlear implants for well over a decade now. Over the next few minutes, we'll be discussing the treatment of tinnitus with hearing aids and combination devices. More specifically, we'll be looking at the evidence supporting the use of these devices in people with chronic tinnitus and hearing loss. Unambiguous definitions provide common ground for researchers and clinicians in order to study and treat problems. So we're going to spend a little time at the beginning by discussing a proposed definition for tinnitus, as well as its proposed mechanisms. These mechanisms are really important as they will conveniently serve as potential attack surfaces for our hearing aid treatment. After that, we'll move on to the device and patient-associated factors which might affect how well a given patient responds to treatment with hearing aids. And finally, I'll wrap things up and mention a few areas for future research, which I think could be particularly beneficial for clinical practice. But first, we will begin with a definition of tinnitus and a discussion of its mechanisms. Tinnitus is commonly defined as the perception of a sound in the absence of an identifiable sound source. Here we have some proposed definitions that have been put out by Dr. Ritter and his group, along with a lot of the TRI and Unity members. So if a patient reports hearing a pure tone or crickets or ocean waves, what they're describing is the auditory perceptive tinnitus. Tinnitus disorder, on the other hand, describes the auditory perceptive tinnitus, but associated with emotional or cognitive dysfunction, which leads to behavioral changes and disability. So if I hear crickets, I have tinnitus. If I hear crickets, and because of that, I can't sleep, I can't concentrate. If my quality of life suffers, then it might be more properly described as tinnitus disorder. Despite the neat and compact nature of these definitions, it's important to recognize the great heterogeneity associated with tinnitus. Different patients can be the same gender, the same age, have the same life experiences, and perceive and experience tinnitus completely differently. So while this makes tinnitus a very complex problem to solve, it also serves to highlight why it's so important to push forward with our work in order to better understand and treat tinnitus. Tinnitus is often cited as having a prevalence of between 10 to 15%, though it can be much higher for certain demographic groups. Of those people affected, upwards of 20% will be severely enough affected that they'll require clinical intervention. In this map, we see projections for the number of people with hearing impairment up to the year 2050. As you can see, dramatic increases are expected worldwide, with similar increases in the rich Western countries of North America and Western Europe, as we see around other areas. If we look at South Asia, we have a larger increase, but the pattern is clear. Across the world, significantly more hearing loss is to be expected. So even if prevalence rates remain relatively stable, the number of people with complaints and the scope of the problem that we're dealing with is going to rise dramatically in coming years. The cause and precise mechanism of tinnitus is not currently known. However, due to the fact that upwards of 90% of people with tinnitus also have some degree of hearing loss, it's generally accepted that decreased input to the auditory system plays an important role. For example, decreased input in the form of hearing loss might result in a pathological increase in gain within the central nervous system, as well as subsequent maladaptive changes in the brain. Numerous treatment modalities have been recommended for tinnitus. Here we're going to be talking about hearing aids. Later on, we'll be talking about neuromodulation. But over on the right, you can see the results of a large national health survey study that was conducted in the United States. And we see a wide variety of treatments that are recommended. All you have to do to recognize the wide span and the creativeness of certain tinnitus treatments is just type tinnitus treatment into Google or YouTube, and you'll really get a feel for the range of treatments that are being proposed to patients. Specifically, what we'd like to talk about with this list that we see over on the right is that various treatment the treatment options that people are recommended often have very much to do with who's doing the recommending. It probably shouldn't be too surprising that medication is by far the most discussed option, at about 45% of patients with tinnitus stating that their physician did at least discuss the idea of medication. In the end, physicians tend to approach problems with medicine. Audiologists approach problems with hearing aids, and psychologists would probably refer to something in the lines of counseling. We end up using what we know best. What's important is that there's a sound theoretical and evidential basis for the treatment recommendations we make. So how might a hearing aid reduce tinnitus? First, by amplifying sounds and therefore adding input to the auditory system, hearing aids might lead to a reduction in central nervous system gain. That increased input might also interfere with the processing of tinnitus in the CNS, and it might even do so well as to reverse some tinnitus-related changes in the brain. As it turns out, the idea that a hearing aid might be beneficial for tinnitus patients with hearing loss is nothing new. Over on the right, we see an excerpt from a 1947 laryngoscope article, one of the earliest that I can find on the topic. And specifically, Saltzman and Erzner state, quote, "A hearing aid will afford considerable relief from head noises simultaneously with improvements in hearing." And so in this article, even back in the late 1940s, they had recognized that a hearing aid, through its effective masking, is able to help tinnitus patients, especially those with concomitant hearing loss. And so while the idea that a hearing aid could improve tinnitus symptoms by reducing communication-related stress and by making the tinnitus and by masking the tinnitus with environmental signals sounds reasonable, it's still important to take a look at the literature to see if these claims stand up to scrutiny. As it turns out, a lot of work is being done currently on the topic of hearing aid-based tinnitus treatments. I did a calculation yesterday and determined that there was one article published on the topic about every day for the last 5 years. Here I provide citations for 3 particularly good review articles, all of which were published since only June of last year. Due to time constraints, I'll only be mentioning some highlights for the rest of the talk. However, if you're interested in learning more, these articles would be a great place to start and to orient yourself in the literature. If you are not so interested in learning more, I suggest the too long didn't read summary that I provided at the top. I actually took this line from the conclusion of a very recent paper by Thaler, where they stated, quote, "In terms of hearing aids and tinnitus, individual differences were large. Many benefited from the treatment, but some did not. We believe this was likely influenced by their expectations." And so this is what we're going to be discussing for the rest of the talk. And also, as you look at the literature, what you'll find is a great amount of individual variability. We see lots of patients who benefit dramatically. We see some other patients who are harmed or their distress increases. And for a portion of the patients, there's no effect at all. So now that we're all thoroughly depressed, let's move on to something that we can control a little better, namely hearing device associated factors that can actually influence therapeutic success. Modern hearing aids can rather accurately be described as ear-level supercomputers. The amount of innovative technology that hearing aid manufacturers are able to pack into such a small space is one of the things that makes this area of research and clinical practice so fascinating to me personally. However, we have to resist and shouldn't let our clinical decision-making be driven by technical capabilities. The fact that we can build some type of feature into the device is not evidence that it should actually be used, and it's not evidence that it's going to be effective. Rather, we need to make sure that our decisions are driven by evidence. And if you review the evidence, one device-related factor is reliably shown to be far more important than all the others, and that is gain. So when we're considering device-associated factors, we think about the different levels of hearing aid technology. We think of all the different functionalities that they have. We think about the number of channels that they have. We think about the automatic processing. And we think we want to do the best for our hearing aid patients with tinnitus. So what could we do? What can we actually pull from the research to say this can be supported? And the primary response is that we should apply gain at the tinnitus frequency. Of course, there's going to be variability, but the study that I present here on the left is rather consistent with much of what you'll read. And so in this study, the authors fit adult patients with chronic tinnitus with hearing aids. Using real ear measures, they adjusted the hearing aids to meet 2 particular prescriptive fits. One we had NAL NL2, and then we had DSL. When real ear measures, when prescriptive formulas are actually used to fit hearing aids, these 2 formulas far and away will dominate the market. What they found was that you need 2 different adjustments to the gain provided by the formula when you're trying to maximally mask or suppress tinnitus. In the low frequency, for both formulas, it was noted that you have to increase gain. So whether you use DSL or now, it can be expected that on average, an increase in gain at the tinnitus frequency, at the pitch match frequency, will be necessary in order to effectively mask and best treat the tinnitus. However, what they also found is that there's a difference in terms of tinnitus pitch. So the changes that need to be made when you're working with a low frequency tinnitus percept is much smaller than if you have a high tinnitus percept. So what that indicates is, though the increases in gain needed for NAL and L2 are going to be larger than for DSL, which makes sense because NAL generally provides lower gain than DSL, you're going to be closer to your target if you have lower frequency tinnitus, as opposed to the larger changes you're going to need if you have a higher frequency tinnitus. So what should we do? If we're thinking about clinically, well, the first rule of thumb would be to actually use real ear measurements verified to prescriptive formulas as a baseline. So this is not the case. It's not to say that these prescriptive formulas are the gold standard and that is the truth for every individual ear, but rather these are very efficient ways to maximize speech understanding and optimize listening comfort in the average person. So this would be our jumping off point for our tinnitus treatment. In addition, what the research suggests is that you should adjust gain at the pitch match frequency as needed to mask the tinnitus percept. And so what you're going to end up doing is you fit the hearing loss itself using the prescriptive formula, and then you locate the tinnitus frequency, and in the smallest or the narrowest band possible, you increase gain at that frequency in small steps until a masking effect is reported by the listener. What we have to remember, this by rule increases gain beyond that what most people accept. And so it's not unlikely that you'll have to deal with increased aversiveness on the part of patients. They'll say certain environmental sounds are too loud, which really highlights the importance of counseling, which highlights the importance of including the patient in what you're doing and making sure that they understand why you're going about it the way you are. There are a lot of more advanced features that are actually the reasons, driving forces why people buy hearing aids and why people sell hearing aids. For instance, we can look at whether or not you can do an open fitting. Open fittings are known for superior sound quality. They're known for being more comfortable. There's also a small amount of research in the literature suggesting that open fitted hearing aids could actually be superior for treating tinnitus patients because they allow more of the environmental noise from the environment into the ear canal and provide a superior masking effect. It's also the case that they could be superior in terms of sound quality, and that could relax the patient, make them more amenable to the treatment. However, on the other side, it's the case that in open fittings, you're going to have less high frequency amplification available to you before feedback. And so you need to be careful when you're selecting, do I want to do an open fitting, a closed fitting, or something in between, to make sure to take the patient's pitch match frequency into account, but not just the frequency, but also the amount of gain that they're requiring. The theoretical foundation of hearing aid in tinnitus is to provide additional auditory stimulation to the auditory system and to, in some way, mask the tinnitus frequency. That's only possible if sufficient gain is applied at that frequency to actually mask. And so it's very critical that we make sure that we're applying the gain where we think we're applying it and that we're applying sufficient amounts of gain where we'd like to have it. Additional features, noise reduction features, directional microphones. Commonly in the literature, it's suggested that they should be deactivated. Basically, everything that can reduce environmental noise might serve to reduce the masking effect of the hearing aid and is bad. However, the research supporting this is also rather light. So I would not say that evidence supports doing this. It could also be argued that by activating noise reduction, the person is more likely to accept the hearing aid fitting. I might be able to decrease their listening effort due to the reduction in surrounding noise. And due to this relaxation, I could have a positive effect on their tinnitus. And so it's not just the case that we want to say gain is all there is. However, we do have to accept that gain is the feature or the factor which most directly affects success with tinnitus, and it should be prioritized. Also things, frequency transposition, frequency compression, there's also little literature in that area. However, fundamentally, the expectation is that as long as we stimulate in the frequency range of the pitch match frequency, we're more likely to have a positive effect. If we use frequency compression and only amplify and only provide signals below the pitch max frequency, then you'd actually expect less success with the tinnitus treatment. So if we're looking at device-associated factors, as I just stated, gain is the most important. We have to provide amplification. However, not everyone agrees. More recently, there's been a series of studies using neuroscience results to suggest that using notch filter amplification is actually superior to conventional amplification. And so in notch filter amplification, you identify the pitch match frequency and you build a notch, or you build a hole in the amplification precisely at that frequency and sharply in the frequency area surrounding it. And by doing that, we're able to use the action of the nervous system itself to help suppress this tinnitus percept. There have been several studies on this topic. At the bottom left, we see the difference in the change in tinnitus improvement when using conventional amplification in blue, as well as when using this notch filtering, or when we cut out gain at the tinnitus frequency in orange. And what we see is at 3 months and at 6 months, we have a significant improvement in terms of tinnitus distress. However, also importantly, note that we had a significant improvement for the conventional hearing aid as well. And so what we're seeing is conventional amplification is going to increase tinnitus. This study suggests that if we notch out the tinnitus frequency, results will be improved further still. This result could not be replicated. In a study in 2020, my group and I assessed in terms of THI and TQ, 2 sets of patients, one using conventional amplification and another using notch filter amplification with a very similar algorithm that was used in the HOP study. And what we found is that on average, patients improved. And so again, it would support the idea that all types of amplification could have a positive effect on tinnitus distress. However, we also had patients that didn't improve. We had patients that were worsened, and on average, these canceled out. And so we could not demonstrate that we had a positive effect of notch filtering beyond that of conventional amplification, which suggests there are lots of variables at play here, and significantly more research is needed before we can integrate this into a evidence-based gold standard treatment philosophy. So, we've talked very quickly, as we don't have a whole lot of time, about amplification, traditional hearing aids. If you provide gain, it tends to help. All other additional features might help, but the evidence is very weak and might go more towards the theoretical foundation for not helping. Well, let's just look very briefly at combination devices, where we have a hearing aid that produces conventional amplification, but we also have the ability to produce some other type of auditory signal. That could be a constant noise, a flat noise, a shape noise, a modulated noise. We can talk about fractals. There are lots of different signals that you can apply. Fundamentally, what we see is that across the majority of studies, the additional use of this noise generator is not superior to the conventional amplification itself. However, it's also not inferior. And so what we're seeing is that there's a lot of overlap. If you apply conventional amplification, tinnitus for the majority of patients will tend to get better. If you apply a noiser or some type of noise generating device, tinnitus percept for a large amount of people, probably around 60%, 65% of people will improve. However, using the devices in combination doesn't seem to have a dramatic impact. Here we see for a control group using conventional amplification, we had 87% of patients improved by a significant margin. In the experimental group with the noiser, we had, again, 87% of people improving. What was very interesting with this study is that we also had people expressing improvement when they weren't using their devices at that moment, suggesting not only are we masking, but we might have some far more upstream effects in the direction of cortex auditory, the central auditory system, that is having more long-lasting beneficial effects. And so we've talked a little bit about what you can do in terms of programming your device, making sure that the gain is appropriate. Are there anything we can look at in terms of patient-associated factors? So when we're looking at patient-associated factors, it's logical to think if we're going to establish different treatment groups and we'd like to know which treatment is most appropriate for which patient, it makes sense to meaningfully group the individuals. And so this has been tried by many different research groups. You can do it based on tinnitus severity. Say that if you have very severe tinnitus, a certain treatment might be best for you. If you have less severe tinnitus, another treatment regimen might be better for you. You're looking at noise sensitivity, the degree of hearing loss, how much hearing loss you have. Do you have aidable hearing? Or are we looking more into the area of a cochlear implant? The shape of your hearing loss, as well as your expectations, all play a very important role. Here we have a very recent study by Boykas where they were able to group a large number of tinnitus patients into 3 groups. We had patients that had tinnitus only. We had patients that had tinnitus along with hyperacusis, hearing loss, misophonia. We had some type of more significant, more emotional effect. And then we had tinnitus together with hearing loss only. And so these were patients that had an acoustic percept, they had a hearing loss, but they weren't suffering too terribly. So what they found was that for the first time, based on these 3 groupings, they were able to make recommendations for the possible interventions that you could recommend. For example, if you have tinnitus together with hearing loss, the intervention of choice could be something along the lines of a hearing aid. If you have a tinnitus, if you only have tinnitus, you could look more in the CBT direction, mindfulness, things of that nature. Whereas if you're going more in the tinnitus together with other issues, it's going to be a much more interdisciplinary type of treatment regimen. If we want to look specifically at patient-associated factors for hearing aids, the quality of the data, again, goes down significantly. Here, I'll give you empirical recommendations that I found in the literature, as well as my personal experiences over the last few years. And don't forget, empirical recommendations are the worst type of evidence that you can possibly have, but sometimes they're the type of evidence that we have. And so that's what we're going to go with here. Given our theoretical mechanism of tinnitus and hearing loss, it is logical to assume that mild to severe hearing loss would be that people with mild to severe hearing loss would be those most likely to benefit from a hearing aid. 1, we have sufficient hearing loss to cause a deficit within the auditory system. And 2, we have little enough hearing loss that we can actually fit it with the hearing aid. We can't forget when we use a hearing aid, it isn't a magic box, but rather we have to apply gain in a certain way. So we have to make that we have effective gain at the pitch match frequency. And we have to make sure that we have it in this particular ear. Just because a manufacturer says we have amplification to 7 or 8 kilohertz does not mean that you have amplification at 7 to 8 kilohertz sufficient to meet the hearing loss in your patient. So this is something that using real ear measurements should be verified in each given ear. We also need patients that are willing to wear devices for 8+ hours a day. These treatments that we're doing, this amplification is a dose-dependent treatment. The longer they wear the hearing aid, the more of a dose, the larger of a stimulus their auditory system is provided, and the greater the downstream effect should be of that treatment. And finally, we would prefer patients that are open to counseling and combination therapies. Even though about 2/3 of patients will respond positively to tinnitus, it's still the case that some of them will not. And it's the case that a hearing aid in combination with counseling or a hearing aid in combination with other types of therapies might improve results further still. And so what we want to do is make sure that we have patients that are open and make sure that we, this idea of client-centered counseling, that we include them in the process, not only because we gain valuable insights, but also because we increase patient buy-in when we do that, and we increase their willingness to to expect good results and to see the therapy through. So the take-home message, obviously this is much too fast for this broad of a topic, but I hope that you've recognized that there's a large body of relatively low quality evidence supporting hearing aid treatment in tinnitus. If you have a tinnitus from 8 kilohertz or down, and if you have aidable hearing, my personal recommendation for treatment of choice as an audiologist, taken with a grain of salt, would be a hearing aid. You are extremely likely to improve their audibility. You're extremely likely to decrease listening effort, to decrease communication distress, which will have a positive impact on tinnitus. However, there's some holes in our research. We need a significantly improved ability to meaningfully group patients, not just say, well, all of my female patients like this and all of my male patients like that. The situation is far too complex to do it at that level. And by saying that, we need increased collaboration between clinicians and researchers. We need our audiologists to talk with our physicians, to talk with our psychologists, so that we can exchange information and make the best decision for our individual patients. And additionally, we need increased methodological rigor. We need better control groups in the research. We also need better reporting standards. For a large number of the tinnitus studies that we review, they'll say things like, a hearing aid was used by these patients for 12 weeks. Well, how much amplification did they get? How long did they use it? How was the situation? What type of signal processing was used? These things are often not even mentioned. And finally, we need to increase coordination between centers. For a large number of these studies, the sample sizes are very small. By increasing coordination between centers, we can optimize our information exchange. We can make sure that our studies are more efficient. We can we can do more than any one center could do. And by that, we can make efficient progress and better learn how to treat our patients using a technology that is ripe to help them. I understand that was very fast, but thank you very much for your attention, and I'll be happy to take any of your questions at the end of the hour.